Good afternoon. This is Kay Lambert from the National LGBT Health Education Center, a program of the FENWAY Institute. We're pleased to have you with us today for the second of two webinars in collaboration with the National Center for the Equitable Care of Elders, focused on providing care to LGBTQIA+ older adults. I would encourage you to look for the first of these webinars, which are available in the Webinars on Demand section of our website. Today's webinar topic is HIV and STI prevention for older LGBTQIA+ adults. This is the second part in a two-part series, and we do encourage you to view part one before viewing part two, which is accessible on our website at www.lgbthealtheducation.org. Presenting today's session are Dr. Kevin Ard, the Medical Director for the National LGBT Health Education Center, and Lisa Krinsky, the Director of the LGBT Aging Project. The National LGBT Health Education Center is a part of the FENWAY Institute, the Research, Training, and Health Policy Division of FENWAY Health, a federally qualified health center in Boston, and one of the world's largest LGBT-focused health centers. Our mission is to provide educational programs, consulting, and resources to help care organizations to optimize their ability to provide accessible, high-quality, and cost-effective care to LGBTQIA+ people. If you haven't already done so, please join our mailing list so that you hear about future webinars, trainings, publications, and resources. You can sign up on our website, which is listed on your screen. Our collaborators for today's webinar are the National Center for Equitable Care of the Elders. Established in 2017, the National Center for Equitable Care of the Elders is a training and technical assistance center that provides innovative and culturally competent models of care, interactive professional training, and educational resources to healthcare professionals who are providing care to older adults. Their mission is to build strong, innovative, and competent healthcare models by partnering with community health centers, primary care associations, and federally qualified health centers like FENWAY Health to provide quality and inclusive care for older adults. You can stay connected with the National Center for Equitable Care for the Elders through many social media outlets, Twitter, LinkedIn, via their website, and via email, all of which are on your screen. The National Center for Equitable Care for the Elders also provides learning collaboratives, webinars, and publications, and I encourage you all to look at their on-demand offerings via their website, and also to connect with them if you have any particular training needs around the care of older adults. We are offering continuing medical education credits for this webinar. When the webinar concludes, an evaluation will automatically show up under the video screen on your computer. We really appreciate receiving feedback from participants. It helps us to improve our programs. And completing the evaluation is also required in order to obtain continuing medical education credits and a certificate. After you complete the evaluation, you'll be given a downloadable PDF CME certificate. This activity has been reviewed and is acceptable for up to 1 credit through the American Academy of Family Physicians. Participants should claim only the credit that is commensurate with the extent of their participation in this activity. Most of our continuing medical education credits are also qualified for CEU credits. If you have further questions, please get in contact with your particular licensing board. The slides for today's webinar will be available through the on-demand section of our website. They're also available on the evaluation page that appears when you close your browser at the end of this webinar. I would like to introduce today's faculty, Dr. Kevin Ard, the Medical Director for the National LGBT Health Education Center and at the FENWAY Institute, and the Director of the Sexual Health Clinic for Massachusetts General Hospital, and Lisa Krinsky, the Director of the LGBT Aging Project. Lisa, I'll now turn it over to you.
Thank you. So I think we wanted to talk today with some learning objectives that we want to be taking a look at better understanding of how ageism impacts for our learning objectives today, to understand how ageism impacts sexual health and aging, to be identifying best practices for addressing sexual health and aging with LGBTQ plus older adults, and then to describe the epidemiology of HIV and STIs among older adults, to summarize strategies to prevent HIV and STIs among older LGBTQ plus adults, and to identify unique considerations about PrEP for older adults. So first I'll start off talking about sexual health and aging with LGBTQ plus older adults. And first, just a quick word about the terminology that we're using today. So we have been using LGBT to represent lesbian, gay, bisexual, and transgender folks for a very long time. We have also seen the addition of the use of the letter Q to represent people who are either identified as queer or questioning. We're also including at sometimes the letters I for intersex and A for asexual or aromantic. And that it's important to realize that for older adults particularly, some of these additional letters and language are not terribly familiar to them. For most of the older adults that I work with, even the inclusion of the letter Q and the word queer is something that still holds a lot of, excuse me, holds a lot of negative historical experience for them in terms of that having been a hurtful slur in their lives. And so frequently we will refer to LGBT or LGBTQM plus individuals. So I want to start off by talking about a real life case scenario today. This happened about 10 years ago when I was called by a long-term care setting that had many male residents, which is actually unusual for much of long-term care. There had been an incident when a staff member walked in on two men who were involved in a sexual activity together. And the staff member's response was, "Stop that right now. What's wrong with you? And what would your mother say?" So what those responses were really communicating sort of sums up a lot of what we see happening around sexuality in older adults. So initially, the staff response of "stop that right now" conveys a message which says your sexual activity is unacceptable. What's wrong with you was clearly communicating that your activity is considered sick and deviant. And what would your mother say, for somebody targeted at someone who is 80 years old, is really judging and infantilizing that person. And so the staff response was really perpetuating the stigma, shame, and minority stress that many LGBT older adults have carried throughout their lives. So these are messages that our folks have heard for decades. Your sexual orientation is pathological, regardless of your age. There's something wrong with you, and that you're seen as a predator. So what was striking to me then about that was I started to ask them sort of what kind of basis did they have for addressing sexuality for their residents, and how was that already conveyed to their staff members? And what we found in the conversation was that they really had nothing set out and planned. There was no real communication given to staff, no real communication around sexuality conveyed to their residents, other than a room where people could have visitors if they signed up for the room in advance. And so again, not creating a space where sexuality is incorporated into the experiences and the lived experience that people living in that community would have had. Interestingly, in just the past few months on Valentine's Day, there was an article in the New York Times entitled "Having the Talk with My 80-something Dad." And it is written from the perspective of somebody whose skilled nursing facility called asking for permission to provide her father with contraceptives. It turned out there was an issue about his cognitive ability, and that's why she was included in the conversation. But it was really striking to me that this merited such a focal response from people. The comments were lengthy. People, half of whom were sort of saying, "Ew, this is gross. I don't want to even think about it," and others saying this is a natural part of people's lives and it should be welcomed and affirmed. What was striking to me in reading was I thought, well, what if the author's father was a gay man seeking intimacy with another man? How would these responses have been even enhanced by that and people's discomfort about this kind of sexuality for folks? We also live in a culture that has historically desexualized older adults. And that whenever we have seen sexual activity from older adults, either they're seen as sort of a dirty old man, or an older woman who's a cougar chasing after someone younger, but that we don't integrate it in a sort of fully embraced way for older adults. However, much of that is really changing. Our current generation is changing with, a TV show like Grace and Frankie, where the two husbands and the two couples leave their wives and form a gay couple, affirming the relationship that they've had for many years, and that the two women who are now divorced are sexually active and talk about and embrace their sexual activity and their aging. And that really is sort of becoming a model and excitement for many more people to talk about sexuality with older adults. The other thing that's striking is we also see the reverse with older adults not wanting their children to know about their sexual activity. So don't tell them about the medication I'm taking, don't talk to them about my relationship with someone else. And so we have this discomfort around older adult sexuality, both from their children and also from older adults themselves. So some of the things that are unique for LGBTQ plus older adults. One is that in the LGBT community, we tend to see a lot of ageism, particularly among gay and bisexual men. And so if being 30 is viewed as being old and undesirable, what happens? What is the messaging that we have about being a 60-year-old, about being a 90-year-old? And that also for many folks in our community, there's been a tremendous amount of resiliency, that having dealt with a lifetime of stigma about their sexual orientation, that many folks are feeling like they can continue to forge a strong foundation and that they can face life as an older adult. The challenges of being older are not distinctly different from many of the other kinds of challenges that people have faced in their lives. For some folks who were previously closeted, they may feel as older adult that it is now safe to come out and to pursue a relationship. For many folks, we hear about this after a significant milestone. It may be retirement. It may be the death of a spouse. It may be the death of a parent. It may be children growing up and leaving home. But people feeling like this is something that I really need to affirm in my life. We're also seeing other people who continue to enjoy an identity and the relationships that they've been in, and that they are deciding that they want to continue to live those rich and full lives as older adults to continue the way they've been living throughout their lives. Also, too, we see many folks who will still adopt for some level of invisibility. Some people will talk about that as discretion regarding their identity, meaning that they're somewhat selective about who and where they share that identity with. And that actually may not be something that they are sharing with their healthcare providers. And so that's important to consider as well. Some of the things that are really striking, and I say this also in this era of now social distancing and social isolation, is what happens for folks who are not in relationships. What is happening to people when that level of loneliness and that invalidation of their identity is considered in the context of a minority stress? What happens for folks who are perceived negatively for being LGBTQ in their communities, and also being seen negatively for being old? And that we are now seeing this migration to much more of a virtual online focus of engagement with one another. And for some people, that's a great opportunity, and that allows them to connect and meet others and be in connection with other people. And there also can be vulnerabilities that come with that. That if we think about some of the circumstances that we've had where people can meet and they can find that connection that with a partner or a relationship, and really forge and sustain that. But we've also heard stories about vulnerability and about what has happened, particularly in a story of one gentleman who was in his 80s, who met a younger man in his 40s and had him move in with him. And very quickly, the younger partner was financially exploiting this individual, was bringing in a lot of his own friends and not letting the owner of the home really use his space. And that when there was any pushback from the older adult, there was a threat of outing him to his family. He was not out to the people in his family and in his community. And there really was a heightened level of distress for this individual, not only about being taken advantage of, in this way, but also understanding what the consequences of that risk may have been for him. So I want to share with you some practice considerations, particularly when we talk about issues around dementia. Back to the long-term care setting, when I was speaking with the folks there, I asked around issues of consent and whether they were able to assess for any concern about the cognitive capacity for either or both of those individuals who were involved in that sexual activity, because that clearly is a significant matter. Both partners must be able to consent to sexual activity, regardless of their relationship status. There have been stories around the country about, there was one story of a gentleman who was accused of rape when engaging in sexual activity with his wife, who had severe dementia and was not really able to consent to the relationship. And he felt that if he was visiting her, that he was in his right to have sex with her, regardless of her ability to consent, because she was his wife. So there were charges taken against that. So we want to make sure that we're protecting vulnerable individuals when we talk about how folks can positively affirm sexuality. Other things to think about around any kind of neurocognitive decline around sexuality is that many LGBT folks are also quite concerned about what may happen around social disinhibition, that for many years they may have spent time in their lives filtering what they think and what they say, assessing where they are, and determining whether or not it would be safe to make a comment. And so this idea that they may not have that kind of filter and may make a comment about somebody else really is anxiety producing for folks who fear that they may out themselves, or they might out their friends or loved ones who might be visiting them, and really being concerned about what the impact of that could be in terms of the level of care that they may be receiving, if so. We also say that people may be expressing a more authentic identity that they had previously hidden. And it may be that it was a circumstance where they are finally sort of being able to express themselves and not having that level of reservation about what they're doing. So some of the other considerations for your practice to think about is, what are your protocols and clinical practices regarding older patients' sexual activity and health? We have many stories of, for example, older lesbians telling us about historically going for their annual medical checkup, having a doctor ask, "Are you sexually active?" being handed a prescription for birth control pills, which they promptly toss in the trash on their way out of the appointment because they were not authentic. And the providers were not able to sort of connect with them and find out about what did their sexuality mean to them. How you communicate regarding sexual health with your patients, that if this is something that you incorporate into conversations that you are having with all of your patients, and finding ways to ask those questions. We know folks have talked about, asking about how you assess for sexual health, and that if you are talking to folks and asking, are you sexually active with men, women, both, or yourself, which is another element, particularly for people who may not be in a relationship, that's important to recognize. And that we want to make sure that, that folks are asking these questions regardless of how old a patient may be. And also to be thinking about how you provide training and support for your provider network so that they are more comfortable. Many times we've heard from folks saying, I'm 30 years old, how am I supposed to ask a 70-year-old if they're sexually active? Well, getting a little bit more comfortable with asking the questions, understanding it, and building up that experience really can be most helpful for folks. Also being able to have conversations about how people may be modifying their sexual activity based on either partner or non-partner, about their ability, is also important to be able to support that as a vital piece of people's lived experiences. So some of the recommendations to sort of carry forth would be really challenge that stigma and be proactive. So the way in which you can not just assume that your patients are heterosexual or cisgender, when you're thinking about LGBTQ identities is also not to assume that older adults are not sexually active in some way. And that being able, as we said, to obtain that standard sexual history with folks, doing it in open-ended ways, as we said, non-judgmental questions, normalizes it for folks and makes it become sort of part of the conversation and the communication that you are having with your patients. What we've also seen in some instances is that by just introducing some of those questions, people not only are able to sort of talk about the sexual activity that they're participating in consensually with people, but there may have been some opportunities where folks have begin to disclose some level of sexual abuse that may be taking place, particularly for vulnerable populations with caregivers or with other people who are exploiting them. And so sometimes thinking that simply by covering these questions and including them for older adults, you are also creating an opportunity for them to perhaps talk about sexual activity that is not consensual and not good for them. Also to be thinking again on a broader sense, that's a little bit more about what you can do as a provider, but also to think about organizational change. You know, how do you promote these protocols of inclusion and respect? How do you make this part of all health centers' lives? So it's not just that one provider who sees more older adults or one provider who feels more comfortable can do this, but that there's a sense that across the board, that regardless of who your patients are encountering in your healthcare center, that you know that they are being asked the appropriate questions, given opportunities to talk about it, and that it's important to also believe that you know, if you would have the conversation around sexuality with someone who is 40, then you can have that conversation with someone who is 80, and that it is important to how you convey that to folks, and really reinforce that this is seen as a normalized part of the human condition, that they may choose or not choose to modify it across the experiences in their lives. But the more that you can be more forthcoming about it and offer it, best that you bring forward and talk about it and then let them say, oh, I haven't done that in 20 years, then for there to be an empty space where you're not creating the opportunity for them to be asking the kinds of questions that are important to them. That's just a little bit of frame talking about sexuality and sexual health for LGBTQ older adults. So now we're going to turn our attention and hear from Dr. Kevin Ard.
Lisa, we'll now focus on HIV and STI prevention for older LGBTQ+ adults. And I'll begin with a case of a patient, a 72-year-old man who presented to urgent care 1 week after condomless anal sex with a man he does not know. He is concerned that he caught something from the contact, but he currently has no symptoms. His past medical history includes high blood pressure, high cholesterol, and arthritis, and he's taking medications commensurate with those illnesses, including lisinopril, atorvastatin, and acetaminophen. He's retired. His wife of 47 years died 2 years ago, and he had never had sex with a man until 1 week ago, but it had been an interest for decades. He met his male partner online, and he did not inquire about the partner's HIV status. So the question here is, what are the next best steps to reduce his risk of HIV and STIs? I want to make the point that HIV does affect older adults. These are data from the CDC from 2017, and they show new HIV diagnoses by age. Now, the most affected age group is the 25 to 34 age group, shown here in the red bar, which accounted for 13,000 infections in 2017. But if you look here at those age 45 to 54, 55 to 64, and then 65 plus, this group accounts for a not insignificant number of new HIV infections. In addition, we know that rates of STIs are increasing among older adults. This comes from the most recent CDC STI surveillance report from 2018. And if you look here at gonorrhea, primary and secondary syphilis, and chlamydia, you can see that the change in rate of reported cases per 100,000 people age 65 plus from 2014 to 2018 increased by 230% for gonorrhea, by 225% for primary and secondary syphilis, and by 148% for chlamydia. And these increases outstrip those for many of the younger age cohorts. I'd also note that human papillomavirus, which can cause anal and genital warts and anal cancer, remains common among men who have sex with men over several decades of life. And this is in contrast to other populations in which HPV peaks in the younger age cohorts and then tends to decrease with time. Among MSM, if you look at any HPV type shown here in green, or the high-risk types shown in red, or the low-risk types shown in blue, high and low risk here referring to the risk for cancer, you can see that these remain common over the life course, at least up until the greater than 55 age cohort. And again, this contrasts with other demographic groups. So what can we do to prevent HIV and STIs for older LGBTQ+ people? And I want to make the point that the strategies we have to prevent these infections for older adults are very similar to the strategies that we have to prevent these infections for younger adults. And here I think in many ways age itself doesn't matter as much as simply taking a detailed and comprehensive sexual history and understanding your patient's risks for HIV and STIs, no matter what their age is, and then offering them proven interventions. So as I mentioned, this really begins with an open, non-judgmental, assumption-free sexual history. STI prevention also includes vaccines, and we'll talk about those for an older age cohort. It includes condoms and risk reduction counseling, non-occupational post-exposure prophylaxis, and PrEP or pre-exposure prophylaxis for those at risk for HIV. To summarize, NPEP is 28 days of antiretrovirals taken after a discrete exposure to HIV infection. That would have been an option for our patient in the case had he presented within 3 days of this encounter. And then PrEP refers to the ongoing use of antiretrovirals to prevent HIV among those who have a high risk for infection. STI screening and treatment are an important part of STI prevention because many STIs are asymptomatic. If we diagnose and treat them, we can then prevent onward transmission. And I'll be talking more about that in a future slide. So all of this begins with an open, non-judgmental, affirming sexual history. So what does this include? Well, it's important to make it routine, make it confidential, and free of assumptions related to age, anatomy, gender, and ability. And I want to underscore age here. Some clinicians assume that people become less sexually active with age, and that's not necessarily the case. And so we should ask all of our patients, including our older patients, about sexual behavior without making any assumptions. The more often you elicit the sexual history, the easier it will become. And it's also important to explain to patients why it's important. I often tell my patients, I'm going to ask you some questions about your sexual history in order to make sure I offer you the best preventive care. And then it's also important to ask about sexual function and satisfaction, not just STI risk. These conversations can often become focused solely on risks and drawbacks and infections and dangers of sexual behavior. But sexual health and sexual activity are an important part of wellness for people. And so it's also important to ask about function and satisfaction. CDC has published a guidance document on a comprehensive sexual history, and this refers to the 5 Ps. And these are shown by the images here. This includes partners, so asking someone about the number and the genders and the anatomy of their partners. Practices, what types of sex someone engages in, including oral sex, penis and vagina sex, penis and anus sex, and so forth. You can also see from the image that another question here is asking about the use of drugs or alcohol in conjunction with sex. A past history of sexually transmitted infections is also important to ask about. The reason is that some STIs require longer-term follow-up. An example there would be syphilis, for which people do require serologic monitoring over time. And also, a recent past history of STIs might raise concern for a risk for HIV and provide an indication for beginning a patient on PrEP. An example of that would be a diagnosis of gonorrhea, syphilis, or chlamydia in the past 6 months in a man who has sex with men. The next P is protection from sexually transmitted infections. The image there, of course, is evoking a condom. It's important to ask about condom use in a non-judgmental fashion. So, for example, asking a patient, how often do you use condoms for sex, if at all? But it's also important to realize that there are other ways to prevent STIs that aren't condoms. For instance, PrEP is an HIV prevention strategy that does not necessarily require condoms. And so I tend to shy away from using the term protection in a question. Do you use protection for sex? Because that could mean many different things. And then the final consideration here is pregnancy plans. So for example, if someone is engaging in penis and vagina sex, and the person who has that vagina has a uterus and has ovaries and has not yet gone through menopause, there is a potential for pregnancy. And so asking if that's desired or not, and if it's not desired, what steps might be taken to avoid a pregnancy. Many of us feel that there is one P here that's missing, and that is the P for pleasure. And again, asking about concerns related to sexual function and satisfaction, not just these items here. So another strategy to prevent STIs is vaccines. And there are really 3 sexual health related vaccines. One is the hepatitis A vaccine. This is recommended for all men who have sex with men, such as the patient in our case. I'd make a point that there is no upper age limit to receiving the hepatitis A vaccine, so that would be indicated for our patient if he had never had it. And it's likely that unless he has traveled or for some other reason received that vaccination, that he's not had it in the past. The second sexual health related vaccine is the hepatitis B vaccine. Again, this is recommended for all MSM. There's no upper age limit on who can receive that vaccine. And I'd also make the point that older adults who were born before hepatitis B vaccine became routine in infancy, that was in 1991, are unlikely to have received this vaccine unless they have had some other indication, such as being a healthcare worker, having chronic hepatitis of another etiology, or having visited a travel medicine clinic. And so they then would need this vaccine, and our patient would need this unless he's had it before. The final sexual health related vaccine is the human papillomavirus vaccine. This is recommended for adults and adolescents through age 26 years. For those between ages 27 and 45 years, it is FDA approved, although it's recommended to engage in shared decision-making about whether or not it would be beneficial. And then for those older than 45 years, there is no recommendation. The vaccine is not likely to be harmful in that age group, but whether or not it's beneficial would depend on a risk-benefit discussion with the patient, acknowledging that there's really a lack of data about benefit in an older population. Another strategy that would be indicated and potentially indicated for our patient in the case is pre-exposure prophylaxis. Again, the ongoing use of antiretroviral medication to prevent HIV. 3 groups have been identified as potentially benefiting from PrEP in the US. These include men who have sex with men, heterosexual people at higher risk for HIV, and then people who inject drugs. Our patient would potentially fall into the top category, and risk factors here that might indicate a need for PrEP include a bacterial STI in the past 6 months, that could be syphilis, gonorrhea, or chlamydia, or any anal sex without a condom in the past 6 months outside of a mutually monogamous relationship with an HIV uninfected man. MSM are thought to, by the numbers, be the largest group of people that might benefit from PrEP in the US, with over 800,000 thought to potentially benefit from that intervention. The second group would be heterosexual people. Risk factors that, again, might indicate a need for PrEP in those patients would be having gonorrhea or syphilis in the past 6 months. Chlamydia among heterosexual people is not strongly associated with HIV acquisition, and so that in and of itself would not necessarily confer an indication for PrEP. And also then sex without a condom in the past 6 months with a partner who themselves has a higher risk for HIV, such as a partner who's a bisexual man, a partner who injects drugs, or a partner who is known to have HIV. And then the final group would be people who share injection equipment. Clinically, PrEP is straightforward. Eligibility and baseline testing for PrEP include excluding HIV infection with a negative HIV antibody antigen test within the past week and no symptoms of acute HIV in the prior 4 weeks. And recall that acute HIV can show up as a mono-like illness with fever, sore throat, lymphadenopathy, sometimes rash. It's important to ensure that renal function is normal, or at least normal enough to receive PrEP. And because the incidence of kidney disease increases with age, this is especially important for older adults. The estimated creatinine clearance must be greater than or equal to 60 to receive TDF-FTC or Truvada, one of the agents used for PrEP. And it must be at least 30 for the other option for PrEP, TAF-FTC or Descovy. And I'll talk more about those options in a moment. It's also important to assess for chronic hepatitis, and that would include a hepatitis B surface antigen, and then a hepatitis C antibody for men who have sex with men or people who inject drugs. I should mention, though, that hepatitis C screening is now recommended for all adults, and so if this patient had not had that, he should have it anyway. And then finally, it's important to assess for sexually transmitted infections. In a man who has sex with men, like the patient in our case, that would include a serology for syphilis, and then gonorrhea and chlamydia testing at all sites that might have been exposed: the pharynx, the urine in a person with a penis, and then the rectum. And then in those who could be pregnant, a urine pregnancy test is important. I mentioned that 2 drugs are available and FDA approved for PrEP in the US. Again, those include TDF-FTC, Truvada, and then TAF-FTC, or also called Descovy. Truvada is indicated for people who have an HIV risk that stems from sexual or drug use behavior. The indication for Descovy is a bit narrower because it's only been clinically studied for PrEP in those whose HIV risk stems from sexual behavior and specifically not from receptive vaginal sex. So we're predominantly talking here about people who engage in anal sex, and their HIV risk stems from that. Again, Truvada can be used to a creatinine clearance of 60 in people who have some chronic kidney dysfunction, where their estimated creatinine clearance is between 30 and 60. Descovy would be then a better option. Truvada is associated with a 1% loss of bone mineral density that tends to happen in the first 6 months and then plateau, whereas with Descovy, there is no change in bone mineral density. And so in an older adult who has some bone loss or maybe at significant risk for that, there may be a preference for Descovy with all else being equal. However, people on Descovy can gain a small amount of weight. The average weight gain is 1 kilogram over 1 year, and then 1.7 kilograms over 2 years. Truvada seems to have no impact on weight. Monitoring PrEP is fairly straightforward and is protocolized in the CDC guidance, which I've referenced at the bottom of this slide. At least every 3 months, people require an HIV test. Again, preferably the antibody antigen assay, because that can detect early HIV infection. They should be screened for STIs. And again, this includes 3-site gonorrhea and chlamydia testing for MSM or for others who have had anal sex or oral sex. And then a urine pregnancy test in those who could become pregnant. At least every 6 months, the serum creatinine should be measured to assess creatinine clearance. And STI screening would be indicated for non-MSM who are taking PrEP. I should mention that, of course, clinical judgment can impact these monitoring intervals. In an older adult who is at risk for renal dysfunction, I might choose to assess the creatinine more often at the every 3-month mark as opposed to the every 6-month mark. And then at most visits, it's important to assess tolerability and adherence to PrEP and reassess HIV risk in an ongoing way to determine if PrEP is still indicated. What are some special considerations regarding PrEP for older adults? Well, as people age, they tend to be taking more medicines. Fortunately, there are not many clinically important drug-drug interactions between the medications used for PrEP and other agents. One exception to this is some of the treatments used for hepatitis C infection. There can be an interaction which raises the levels of tenofovir in people who are taking both PrEP and some hepatitis C treatments. That's often not clinically significant, but in a patient with borderline renal function or some risk factors for renal dysfunction, you might choose to monitor kidney function more closely in someone who is taking both of those medications. Coexisting renal or bone disease, which do increase as people become older, may complicate the use of PrEP, and that's especially true with TDF-FTC, which tends to have more impacts on renal and bone than TAF-FTC. So for someone for whom TAF-FTC would otherwise be indicated, such as an older MSM, you might prefer that agent if there were coexisting renal or bone issues or strong risk factors for those. And then I would also mention that there is really no official guidance about bone mineral density monitoring in older adults who are starting PrEP, or really any adult who is starting PrEP. You might consider baseline testing for those who have other risk factors for osteoporosis, just so that you can have a baseline before they begin the medication and then assess it over time. I also want to mention that most PrEP clinical trial participants have been young. I've listed here on the left-hand side of this table some of the different randomized controlled trials of PrEP, and then the populations that were the focus of each of these studies. You can see this includes MSM. Some of these studies included transgender women. There were also studies among heterosexual people, and then people who inject drugs. And then if you look at the age groups on the right-hand side of the slide, in many of these, 10% or even smaller proportions were older than 40 or 50 years. And if you start to think about people who are in their 70s or 80s, they would be quite rare in these studies. And so the evidence base for PrEP that we have is primarily in younger people. And so I think we need to keep an open mind about how toxicities from PrEP might evolve in older adults and follow our patients closely, though I certainly would not hesitate to prescribe PrEP to an older adult who might be at risk for HIV. And the patient in our case, who recently had condomless anal sex with a man he does not know well and who is of unknown HIV status, should our patient be HIV negative, might be a prime candidate for PrEP going forward. I do want to highlight CDC's screening recommendations for STIs for men who have sex with men, because as I mentioned before, screening and treatment of STIs is an STI prevention intervention from a societal perspective. CDC recommends that MSM have an HIV test at least once a year. For those on PrEP, that would be every 3 months. That they have a syphilis test, and then again, gonorrhea and chlamydia testing from all sites that might have been exposed. Technically, it's only recommended to assess for gonorrhea in the pharynx, not gonorrhea and chlamydia at that site, but the test is simultaneously run for both. You actually can't separate the gonorrhea and chlamydia assays on the platform, and so chlamydia testing will be performed at the pharyngeal site as well when you swab that site. At least once, they should have a hepatitis B surface antigen. Again, that would be required as part of the baseline assessment for PrEP. And then if they're living with HIV, a hepatitis C test should be performed once a year. What about other populations, non-MSM? And here there are less clear guidelines, I should say. Although CDC does make this statement about transgender people, they say that clinicians should screen for STIs and HIV based on current anatomy and sexual behaviors, And again, you would only know that through an open, affirming, non-judgmental sexual history. They also say because of the diversity of transgender persons regarding surgical affirming procedures, hormone use, and patterns of sexual behavior, providers must be aware of symptoms consistent with common STIs and screen for those based on behavioral history and sexual practices. There are separately no STI screening recommendations for women who have sex with women. Before I end, I also want to make the point that PrEP itself may be an STI control intervention among MSM. And you may ask how that could be the case, as you may have been aware of data that STI diagnosis can increase after people begin PrEP. And again, what this comes back to is frequent STI screening and treatment as a control intervention overall. So based on a modeling study, if you took a group of men who have sex with men, and you were able to get them, 40% of them onto PrEP. And I should mention that is better than what we're doing as a society right now. So this would require more PrEP scale up than what it exists right now. But if you were to do so, and even if those individuals reduced their condom usage, which we have seen in studies of PrEP, still, you could prevent around 40% of gonorrhea and chlamydia infections in this population over the course of 10 years. And that's because PrEP is not just a pill. It is a sexual health program in which these men would be having every 3-month assessments for gonorrhea, chlamydia, syphilis, and HIV. Again, many of these STIs are completely asymptomatic. You would only know that they were present if the patient was tested. And if you test them and then treat them every 3 months, you could then prevent these infections from spreading and then reduce the burden of those infections over time in the population. So what happened in our case? Well, unfortunately, our patient was outside of the 3-day or 72-hour window for PEP, but he was counseled about this intervention for future reference. We did test him for HIV, hepatitis C, gonorrhea, syphilis, and chlamydia, and fortunately, all of that was negative. He was not immune to hepatitis A or B, and we vaccinated him for both. We counseled him about condom use and made sure he had access to condoms. And we discussed PrEP. It turns out that he was interested in exploring his sexuality more and wanted and anticipated that he would be having sex with other men going forward. And he wanted to protect himself against HIV. Because his creatinine clearance was 57, we began Descovy or TAF FTC for PrEP, because PDF FTC or Truvada would not have been an option with that level of renal function. And he expressed an enormous amount of relief that he could discuss his sexual behavior and his desire openly with a provider. And he kept coming back to how grateful he was to have this opportunity to talk about this aspect of himself and to explore it. So what I hope that you take home from this portion of the webinar is that STIs are increasing among older adults, and sexually active older adults remain at risk for HIV and other STIs. There are multiple strategies that are available to prevent HIV and STIs among older adults. In many ways, these are the same strategies that we use in younger adults. And so really what matters here is not so much age as the features of someone's life and what their sexual behavior is. A necessary first step here is a sexual history, which should be free of assumptions about age, ability, and the gender and anatomy of one's partners. I want to thank you very much for your attention.
Thank you so much, Dr. Ard, and thank you, Lisa Krinsky, for that wonderful presentation. I want to remind everyone that this presentation will be made available on our website, www.lgbthealtheducationcenter.org, for CME credits ongoing. You can also download the slides from the webinar unit on our website. Please also take time to look at our website, see the other webinars that we have available on demand for free CME credits, and please recommend this webinar to anyone you think could benefit from its content. Thank you so much for joining us today, and we'll talk to you soon.